Good afternoon, everyone. My name is Jessica Richwalder, and I am a senior staff attorney at Disability Rights New York. I'm so happy to welcome you to today's panel discussion, Willowbrook and the Road to Inclusion, Ableism and Access to Healthcare Systems. Disability Rights New York is so grateful for the great attendance at this afternoon's panel. This is the third event in our year-long series of events commemorating the 50-year anniversary of Geraldo Rivera's groundbreaking expose on the shocking conditions at the Willowbrook State School for People with Disabilities. The school was located on Staten Island in New York, and the exposure of the abuse, neglect, and inhumane treatment of people at the school is often credited with sparking the public outcry that led to the federal civil rights legislation that today provides the framework for Disability Rights New York to fight for the rights of people with disabilities to be treated fairly, equally, and have access to all aspects of life. While we have certainly come a long way in the past 50 years, this series is dedicated to Willowbrook to also acknowledge that we still have far to go. Today's panel will focus on ableism and access to healthcare systems, and the discussion will recognize the work that still needs to be done to allow true access to healthcare for people with disabilities. We have two wonderful panelists who are here today to begin this discussion for us. And so I'd like to allow them the opportunity to introduce themselves at this time.
Hi, well, it's nice to be here today. So hi, my name is Peppar Cyr. I use she, her pronouns. I'm a half white, half East Asian woman in my late 20s. I'm wearing a white collared shirt with a pink cardigan on front of a plain beige wall. So I'm an MD PhD student at Washington University in St. Louis. I've completed the classroom part of medical school. I'm getting close to the end of a PhD before I do the clinical part of medical training. And I became interested in disability and this whole sort of disability and healthcare space because I was born 3 months early and weighing about 2 pounds of 1 ounce. And my parents were very open about like what that meant in the early, hospital stage and things related to that. And so I like to say I was probably the only 6-year-old you could meet who would say, I want to be a neonatologist. But really my entire life, I've been working to try to, make sort of impact for other people that was made for my life. And then getting into part of my life kind of just before and into medical school, came to realize that while early on people had thought I had sort of made it through not disabled, that wasn't quite as accurate as they thought, and then began adding in a more of a disability advocacy lens to the things that I work on. And so I'm looking forward to having a career working with disabled kids in one of many possible areas of medicine, and currently work on both continuing my training as well as bringing disability inclusion into medical education.
And hello, my name is Diana Cejas. My pronouns are she, her, hers. I am a Black woman who has a little bit of an afro puff today. I'm also wearing a mask, but I'll probably be removing it during our talk. I have someone who's in the room with me who'll be leaving. I am also wearing a little floral dress today. And I am sitting in front of a half pink, half beige wall here in my clinic. I am a pediatric neurologist at the University of North Carolina at Chapel Hill, and also faculty of the Carolina Institute for Developmental Disabilities, meaning most of my clinical work, research, advocacy, and other efforts all center around the field of IDD in some kind of way, neurodevelopmental disabilities. I first got interested in working in the disability space just kind of naturally as I started to learn a little bit more about how just very, very many different ways that neurological conditions can affect development. Really started getting heavily involved into disability work and more disability-focused advocacy during my medical training. So I am a person who is a cancer survivor and a stroke survivor. I had my illness while I was in residency, which was certainly an eye-opening experience for me. And as I went along in training, I certainly already had the context for how the healthcare system doesn't necessarily work for people of color, people who are lower income, like my particular background, but certainly got a better look at how it doesn't work for the disability community as I was trying to access care as a person with a pretty significant amount of privilege, being that I was in medical school and then in residency as I was going through all of this. But really that got me interested in trying to figure out how we could make things better for particularly young disabled people of color, how we as clinicians can provide better care, what we can be doing to improve our communication. So that is what most of what I do is at this point. My research is all around improving health equity and health outcomes, particularly for young disabled people, and especially as they transition from the pediatric side of care to the adult side of care. So I talk a little bit about ableism in lots of different places. I'm really interested to have this talk today.
Thank you both so much. And so I want to start our conversation by giving a generic definition of ableism. If you were to look this up online, it would be defined as ableism referring to bias, prejudice, and discrimination against people with disabilities. And it hinges on the idea that people with disabilities are less valued than those who are not disabled. And it is believed that 1 in 5 people in the US live with a disability, and worldwide, people with disabilities represent one of the largest marginalized groups, making up approximately 15% of the global population, according to the World Health Organization. So I want to invite our panelists to expand on that definition in any way that their backgrounds allow them to, and ask how they would define ableism, and also ask if there are any particular examples of ableism in their professional work that jump into their minds.
Yeah, so I like to refer to the definition of ableism that was in Emily Ladau's book, Demystifying Disability, that says, ableism is attitudes, actions, and circumstances that devalue people because they are disabled or perceived as having a disability. And I think it's very similar to this definition that you brought forward there, but I think also adds that important piece about being perceived as disabled. And I think that's important both because of, obviously a lot of what is done to someone is based on other people's perceptions, but also to bring up the idea too that there's kind of a flip side that people sometimes put a lot of work into not being perceived as disabled by other people to try to avoid ableism. And in terms of what that has looked like that I've seen in a healthcare setting, that can be something very overt and explicit. Like sometimes if you go looking into things like eligibility for certain medications or procedures, especially things like transplants, you can find that certain categories of disabled people are just by rules excluded from these things. But it's also a thought, a lot of places this can be a lot less sort of in your face obvious. And we can go into this a little bit further later, but particularly egregious in my opinion are situations where you have a healthcare service that is specifically for a particular disabled group and yet is also specifically inaccessible to that same population. Diana, what you'd like to add?
Yeah, absolutely. Certainly thinking about, and I completely agree with the comments that have just been made, specifically thinking about how I think when people think about ableism, as they think about lots of different forms of discrimination, they think that it is always this in-your-face kind of a thing, like someone saying something rude to you, calling you rude names, using ableist language. And of course, all of those things are examples. But if I'm thinking about like my own, just how things are not made for disabled people, thinking about the fact that I'm in a clinic right now and I'm having to use my phone because of some technical difficulties, but I have a table over here, which we ask our patients to get up on, and that is completely inaccessible to a person who might have some mobility issues, who might be a wheelchair user. So even a place like a hospital that is supposed to be something that is accessible to disabled people, because you would think disabled people would be the biggest consumers of whatever services we're offering here, is still not accessible to people with disabilities. So even those things that seem very small, but are examples of structural ableism are something that we see all the time.
Thank you both so much. And what would you say is, and I know this is a broad question, is the impact of that inaccessibility and ableism? Have studies observed that folks with disabilities simply don't seek medical care, or that it results in less quality care?
So yes, there's been some research that came out specifically about autistic people done in the UK, and was showing that autistic people have poor, shorter life expectancies, but they get into really about access to healthcare, and described a lot of the barriers with accessing both primary care as well as emergency or specialty care, and higher mortality rates at every step of the process, that part of which the study attributes to delaying accessing care because of the barriers involved in trying to do so. Things like, for this population, being required to make phone calls in order to make appointments might make somebody feel like I can't do that. And so delay seeking care until it's something that lands them in the emergency room in a much more, severe condition than they otherwise might have been. So it's definitely something that across, that's just one example, but across a lot of populations, this is a big problem.
Yeah, I totally agree. And thinking about, delaying care, other things that might be going into that and might be putting up barriers for disabled people. Certainly, I don't want to downplay the effects of interpersonal ableism, particularly since so much of how we practice and so much that is within medicine is inherently ableist. Where you have people who, for example, working with patients who might need a mobility device, who are younger than, whatever is supposed to be the age that you're supposed to be able to have one. And just the stigma that comes with someone trying to access those devices from the medical providers, who will say things like, I don't want you to have this as a crutch. I don't want this to be something that you rely upon, and really saying things that are very negative, can really contribute to, I think, the deterioration of the doctor-patient partnership. And that also can lead people to kind of delay seeking care, because, of course, why would you want to come to a place where you're thought to be either trying to game something from the system or access something that you're not supposed to access, and you're coming to a physician that's supposed to be helping you.
And building on that too, bringing things kind of into the current moment, the decrease in some areas, and some of this also was coming out of the UK about lower quality or less common mask use in healthcare settings, where in some places it's becoming optional, creates a lot of people reaching a situation when they're trying to weigh the risks of not receiving their healthcare versus potentially being exposed to COVID, particularly if they have, any of the many conditions, if you look on the CDC website, that can predispose someone to a more severe case of COVID. So that's another kind of piece where people are really torn about accessing care, or really care being accessible to them.
Absolutely. And do either of you have any COVID-19 specific observations where you've noticed aspects of ableism become more prevalent in the last few years?
I think one of the things that immediately comes to my mind is this whole discussion about quality of care and goals of care. And certainly during, I don't want to say the height of the pandemic, because it seems like we are reaching new heights every day, but there were so many different discussions about who should receive ICU level services, rationing care, who should receive a ventilator. And of course, every time you look at it, if you look at someone who has any kind of disability, particularly those with intellectual and developmental disabilities, and particularly those people who might have more significant physical limitations, or maybe who are already using different kinds of technologies like ventilators, it seems like their lives are considered to be just kind of less valuable. And those would be the people who, if you were going to ration your healthcare, those would be the people who would tend to be seen as the person who needs to be saved. So there's been a lot of conversations about what quality of life means, how even that can be inherently ableist if you're looking at the person, who might be an abled kind of provider who is determining what quality of life really means, and how that all comes into play when we're talking about life-saving measures for people who might be in a COVID-19 situation.
Absolutely.
Yeah, a little bit off of what you said, but just building off that idea about the ableism in the concept of quality of life. A lot of measures around quality of life were designed and created by abled people, trying to imagine what it would be like to be varying types of disabled and how they would feel about that, instead of actually consulting people who have various kinds of disabilities about what their life is like and why. And so that's just it's a very thorny concept when you get into that.
Thank you both. Have you had any aspects or instances of ableism that were particularly surprising to you in either your research work, your schooling, something you've experienced personally or observed against a person with a disability?
Yeah, so one of the projects I've been working on more recently has been trying to get more disability content into our medical school curriculum, making sure that our students are learning how to take care of disabled patients. And I was a little bit surprised that I got pushback early on when I tried to integrate that into our preclinical time, that this is like inherently advanced content. You can't like give that to the first year medical students. And I was like, wow, I ended up reframing it as disability content has its own beginner content, intermediate content, and advanced content. And it is never too early to be teaching our, future healthcare providers basic stuff about disability etiquette and what is ableism, even before we get into things like how do you modify taking history? How do you modify doing a physical exam to work with a wider range of people? But it was just like, wow, this is not inherently advanced content. On the clinical side, recently I was shadowing on the sort of general medical floors in the hospital. And there was a patient who, for good reason, team didn't want kind of getting up and walking around and trying to do these things by themselves. But this had resulted in the patient being kept in their room, really in their bed or in the chair next to their bed, pretty much all of the time for a while. And the patient was upset about this. And the team's response was talk about how, PT is going to be coming soon and we're going to be working on getting you up. And the main thing really was that when I brought up to the team later, has anyone asked the patient how much they're upset about not being able to get up versus being stuck in their room? And maybe we could get a wheelchair and let them out a little. Just the fact that this seemed to blow their minds. Like I would have understood if it was something like they were like, oh yeah, we totally forgot. We've been so focused on this thing that we didn't see the bigger picture, but just the reaction. Oh, wow, that's such a good idea. I wouldn't have thought of that. It was a little surprising.
Yeah, I wish that I was less surprised about some of the things that I come across either in the clinical setting in research or what have you. One of the things that kind of comes to my mind is one of the things that has been most surprising to me is how many people still hold on so tightly to just ableist thoughts about people and their abilities who work in disability spaces. Particularly a lot of people who might not necessarily be a person with a disability, maybe they don't have, life experience. Sometimes I'll be sitting in meetings and just be thinking like, I cannot believe that you said that. And these are people who are really well respected. They're doing amazing work. They're bringing in lots of grant funding, or they have all these accolades. And then you hear something profoundly ableist come out of their mouths. And it's kind of like, sometimes I think that it is not done intentionally, but then at the same time, I'm like, well, what does that say? Someone can get to like the highest echelons of this field and still have those kinds of thoughts. So I think that is something that's been surprising every time, disappointing every time, but then also kind of lets me know that there's so much that is not even thought about or known about ableism, like as part of, a person's expertise or, required training.
And to build off something that you both just mentioned, schooling and training, in your schooling, your training and professional work, have you received training targeted on teaching about ableism and implicit biases against people with disabilities that you've found helpful? And if you haven't, do you have any thoughts on what would be helpful? It sounds like Peppar was already working on that a bit in her own sphere, but I'd love to hear more about that.
Yeah, so in terms of direct medical education, I kind of alluded to before, I've only been through the preclinical kind of classroom part of medical school. And in that, I can remember one session where we had, where they were trying to sort of challenge our ideas about disability a bit. We were doing a session where we were interacting with actors to practice taking a sexual history. And one of the actors sort of we rotated through was portraying someone with cerebral palsy. And we had to realize that the person with cerebral palsy does not mean that they cannot also be having sex and in this case, contracting a sexually transmitted infection. But that was all. And so as my school is currently in the middle of overhauling the curriculum, I've been really enjoying taking advantage of that opportunity to try to insert more content. And as I said, trying to build that across the whole curriculum in sort of increasingly complex ways with that sort of basic content, things I wish everyone knew, but they don't in the preclinical space. And students are building their clinical foundations in their main clinical rotation year, trying to at least just introduce some ideas about how you might modify your physical exam or modify your history taking to work with different sorts of people. And then we're working on building an elective course for the final year that really takes a much deeper dive into what kinds of things disabled people can do out in the community, because medical training is really heavily inpatient inside the hospital focused. And if our trainees aren't seeing a lot of, are not having a lot of interactions with people that they know are disabled outside of that setting, it can create a really skewed view of what a disabled life is like. So that's part of that inspiration for that course. But also that course is being taught by 2 physicians, one from our physical medicine and rehabilitation department, and one from occupational therapy, who are both themselves visibly disabled. So I'm really hoping to make that impact from day one to the students to see, like, look, this is, disabled people can have lives, they can be your professors. But yeah, so really trying to make sure it gets built into the curriculum in a way that challenges people to see disability in more contexts than they otherwise would, and to recognize that there are a lot of little things you can do to make someone feel a lot more accepted and to have more successful interactions with your patients that are not going to be as grounded in maybe knowing every single medical detail, but being willing to ask your patient, things like, wow, you just list all your medications for me. That's a lot of things. How are you keeping track of them all? Asking about their activities of daily living at home and how they're doing that, and if that might need to change. These are things that I'm getting told when I do them in practice patient sessions, that this is like, oh, wow, you're doing a great job. Those are so advanced things. But in a way, they're the easy things, because I don't need to remember the details of, lung physiology to remember to ask somebody, if you've been short of breath lately, is that harder to get up the stairs in your apartment?
I always love hearing you talk about the things that you're trying to do at your medical school, and knowing that there are other students that are out there trying to do similar kinds of things and changing their curriculum so that you start to get your disability education as soon as possible, as soon as you go into med school. Because for me, I did not really get any disability focused training until my very last year of training. And so I was actually a participant in the LEND program, the Illinois LEND Leadership, Education, and Neurodevelopmental and Related Disabilities program, which was something that I had no idea even existed until I happened to rotate with a developmental behavioral pediatrician who thought, because I was interested in some of these disability issues, he said, why haven't you applied for this program? I said, I had no idea what it was. And that was the first place where I was able to, one, sit in a room with other people who were self-advocates, family advocates, who had lived experience with disability. Like I did, but in a different kind of aspect, because most of them were people with neurodevelopmental disabilities and autism. But really to sit in a room with disabled people as colleagues, along with other colleagues, so other physicians, other members from allied health teams like physical therapists, occupational therapists, speech therapists, people who were getting their disability studies PhDs, and we were all together in the same room talking about the same topics, learning about the same topics, and learning about how we approach them from our individual disciplines and with our individual life experience. Again, that was something that I had no idea existed. And at this point, I was like, this is after 4 years of medical school, 3 years of PEDS training, 2 years of my child neurology training, 2 years of a master's, and something I had no idea even existed. So it was something that I was hoping that, more trainees at my particular institution would be involved in. I really started to champion for it, but of course I was only there for a year. I finished up with my training in 2017, and they just finally had a trainee who's going to be in the LEND program again starting this year. So, and I think that that's just, because there are so many schools, so many residency training programs and other kinds of continuing health education for clinicians or physicians in particular, where disability is not seen as identity. where we don't look at disability from any other model than from a medical kind of a model, where when we're talking about disability, we're talking about something that needs to be cured or something that needs to be fixed or something that needs to be, we should be doing something about that. We don't actually talk about the disabled person and what they're dealing with, what they're going through, what they might see as disabling, and it might not necessarily be their individual physical limitations. It might be something that actually society is placing upon them. So I'm happy to know that there are more people out there that are trying to get this kind of disability education embedded in early, but also at the same time recognizing that there's so many institutions where that just isn't happening yet.
And what type of reaction would you both say you receive when you advocate for and talk about ableism in healthcare and wanting to see more education and discussion about people with disabilities accessing healthcare? Do you find that your peers are open to this information? Do you receive negative feedback?
When I started in this work about 5 years ago or so, I think the reaction I got from a lot of the faculty that I kind of just cold set up meetings with was, oh, wow, that is, interesting and important. And, we should do something about that, but not a whole lot of, push and engagement to make something happen. But thankfully, right around shortly after that was when we started really overhauling the curriculum. And so with the new wave of thinking, a new set of people being involved, I've had way more support. In particular, the Dean of Education at my medical school has been one of my biggest supporters. And so I think it's something that's really been changing a lot and making a lot of progress over the last several years. But I also recognize that the sorts of people that I'm mostly talking to who are working on building our new curriculum are a very self-selected population who are really interested in improving and especially bringing a new, one of the threads is called health equity and justice, but bringing that social components into medicine. So the front edge and things is definitely on board, and it's growing, but there's still a good way to go.
I totally agree. I think that there seem to be quite a few people where, they might not necessarily have been thinking about this before I bring it up, but they have been responding to it pretty positively. I've noticed that tends to be, at least in my field, it tends to be, the students, the trainees, the junior faculty, everybody is super excited about it. It's like, okay, this is amazing. And even if there's not as much, there aren't as many accomplices, I guess, and willing to kind of do the work to kind of push it along, at least they are open to doing the work, once they get a little bit of guidance. I have noticed that there is some pushback sometimes from those people who are higher up the chain. And I think that part of the reason for that is just that it is a completely different way of talking about how we are going to approach the way that we deliver care. And also, I think a lot of it, particularly when I'm talking about the experience of how intersectionality kind of comes into play here when we're talking about how we deliver care to people of color who are disabled, what that looks like, what that means. It means a lot of people have to start to kind of reckon with their own biases. That's always hard to do. And I don't want to say it's harder to do for people that are further along in their career, because I don't believe that that is true. But I do believe that maybe they haven't had as much. I think that, lately there has been so much more of a push to look at, things like social determinants of health, however you feel about that phrase, to look at racism, to look at ableism, to look at how all of these things kind of come in. So you've got students who are coming in with these kinds of thoughts in mind. So the idea of talking about it from a disability perspective isn't as, foreign, new, and scary to them. So again, I think that, there have been people who have been really excited about the idea, who are willing to learn. And occasionally we will have those kinds of bumps in the road from people who are higher up, who don't really see kind of the point, or who kind of bristle at making these changes.
Thank you both. I wanted to shift our topic a little bit here to something that I saw mentioned in the chat that I know that Peppar had specifically talked with me about before we started today, which is medical research and how ableism impacts medical research. And that's both from the lens of are folks with disabilities participating in medical research or invited to participate, and then also whether there is funding and research happening on how to best serve people with disabilities.
Yeah, ableism is definitely a problem for medical research as well. And I think that, as you're talking about, manifests in several different ways. So, you talk about funding a bit there. I have some colleagues who are trying to do research into aspects that are not as medically focused, but are still about disabled people and disabled lives, services, activity, et cetera. And the funding organizations and pools are just so much smaller for that. Most of things when we think about, medically related research is going to be through like the National Institutes of Health, which is mostly focused on the more biological components of, disability and life. And then the second piece, though, is about participation in research. And I think about that in two main areas. So one is what you alluded to about being a participant, someone who, provides data for a research study. And the issue there is often around exclusion, unnecessary exclusion. Specifically, there's been some studies looking at how often disabled people were written into the exclusion criteria. So the list someone makes when they're planning a study, here's who's going to be in our study population and who are we not going to have in our study population, and found there was a lot of studies where disabled people were explicitly excluded, even though if you looked at what they were studying, there was no reason why they couldn't have disabled people in their study. Or sometimes it's a little more implicit there where they're not listed out specifically in the criteria, but when someone might come in for the study visit, you discover that the things that they're being asked to do are not being made accessible. So that's kind of one piece. But then the other piece, which I think is in some ways even more important, is including disabled people on the research team in a variety of formats. There are a lot of ways that can be done. There's starting to be more of what we call participatory research or co-design. There's a lot of different terms out there, but one area where this has been a bit in the news about a little less than a year ago was the Spectrum 10K study in the UK, which was a study that was looking at a variety of genetic and other factors, trying to recruit 10,000 people, hence the 10K, looking at autism. And within a few weeks of starting enrollment, it was shut down because of massive protests from the autistic community that they were not okay with what kinds of questions were being asked, how the process was being done, and just the way that the study was being run. And so that's now in a multi-year long project to revamp the study, involving a lot more autistic people in deciding what are the kind of questions that we're going to be studying and how we're going to go answering them. Personally, as a researcher, sometimes I've stopped going to talks about conditions I have because of just hearing people like me talked about in such negative, pathologizing ways, talking about risk for growing up to be like me or things like that. It's hard to work in.
Yeah, I totally agree. And thinking about the fact that when we're talking about research, and even when we're talking about training people to do research, to get involved in research, to look at funding sources for research, most of the time you're looking at these kind of funders which are coming from more of a biomedical kind of a model, who might not necessarily be interested in kind of more participatory research or research where you're actually partnering with members of the disability community. I know for me, when I really started to get involved, everything was about getting NIH funding and securing NIH funding. But when you look at the calls for submission, they might not necessarily be interested in doing the kind of, like, let's say, qualitative work or patient outcome-centered research or things like that. So I think that even the way that we kind of train people to get involved in research is not going to be the way that tends to lend itself to doing that kind of work where you actually are engaging the disability community. I think another issue, especially one that I've been thinking about quite a bit lately because of some of the studies that I'm trying to work on right now, is this idea of engagement and what that means, and actually how we are able to recruit disabled people to be partners on the study. I think that there's just been a long history in medical research where we're just kind of using disabled people as like our subjects, and that's it. And there's no kind of like, we take your data, we're coming in as researchers, we're going to tell you what we're going to do, we're taking your data, maybe we give you like $50 or some food or something like that, and then that's it, that's all. And there's really no follow-up with the community as to how the research that we've done has benefited them, what they can kind of expect to see as a result of this research, to get their follow-up, to get their thoughts about the research after it is done, or even to partner with them for, you know, additional studies moving forward. We're always thinking about like what the next study is going to look like. And I think that's particularly true for, you know, other minoritized members of the disability community. I think researchers in particular have done, again, I'm thinking about the fields that I'm working in most of the time right now. And when we look at participants in the research studies that we're doing, they're largely white, they're largely at a higher SES. These are people who are more connected. These are people who are able to, you know, get involved in research in the first place. On the one hand, it's like, I'm glad that we're able to collect that data, but what does that mean when we're trying to extrapolate it to the rest of the community who maybe does not look like that or have that kind of life experience? So I think, really thinking about like how researchers can actually meaningfully partner with the disability community, especially knowing that there is this contentious history between like the disability community and researchers. That's something that we're really going to have to do a lot more work on if we actually want to be, you know, having this kind of participatory research.
Yeah, and also tying back into the idea of having science that can actually be used, because there's been some work looking at a mismatch between who's allowed to be included as a participant in certain like large, you know, treatment clinical trials versus the population that actually would be receiving the kind of treatment this trial is about. And there have been some studies that find that, you know, less than a quarter of the population that in this example is discharged from the hospital with heart failure would have been eligible for the trials that were determining what kinds of medications and treatments were going to be offered to these people at that point in their care. And so you're not thinking really about that, you know, matching up who's allowed to be in your study versus who you're actually treating has a huge impact across a large portion of the population.
Thank you both. We have about 15 minutes left, so I did want to give the opportunity for anyone who might have a question. You can either place the question in the chat, or if you want to use the raise hand feature, then you can ask your question that way as well.
Mark, if you would like to unmute yourself to ask your question, I know in the chat you had said that you had one.
Sure. I'm okay now.
Yes.
Thank you so much for your work. I'm Marc Flieder. I'm a director here at DRNY. Thank you so much, and thank you for sharing your observations with us today. James just put in the chat a moment ago a topic that I'm always struggling with when we're trying to get the word out about the great work that folks like you are doing, which is that the systems within which you work and other systems where I need to give suggestions soon, basically the court system, are all focused on hurry up, you got to get it done, we're on the clock. And you all know that sometimes meeting the needs of folks with disabilities requires us to build in a certain amount of time to assure accessibility and the needs of the particular individual. How do you, when you're trying to address these issues in the systems in which you're working, how do you suggest that healthcare build that time in, and how do you get the administrators that you're trying to teach about these things to value that aspect?
So I haven't gotten very much into the clinical space yet, but from what I've heard from other people, one potential avenue would be pointing out how much time can be saved later by addressing some of these things sooner, fewer repeat visits, shorter lengths of stay, just a lot of complications that don't have to happen. But I also know there's a lot of emphasis on sort of what's happening right now. I don't know if Diana has better ideas.
Yeah, I mean, I think usually when it comes to trying to convince people to get invested in these kinds of things, what I'm usually trying to do is get them to kind of see the dollar signs and see the savings, which unfortunately a lot of the things that I think would be most beneficial to disabled people are not going to be those things that are saving like enormous amounts of money up front. It's going to be something that you're looking at like 5 years from now, 10 years from now, something like that. I think I've been lucky in that the center where I'm working now has a really big focus on interdisciplinary care. But even with that, like I'm thinking about one team that I'm on where we are mostly, so it's neurologists, psychiatrists, complex care pediatricians, some parent navigators, some psychologists, and other members of the team. And our goal is to really work on trying to make sure that we're, one, actually talking to each other as a group, and two, trying to make sure that we're getting coordinated kind of services to kids who have complex neurological and psychiatric conditions kind of all at once. And it is a team like that is like, I think we do a really good work, but at the same time, I think everybody on the team recognizes that we're not really getting paid that much to do it. And then also what we're trying to do is what the funding that we have gotten to kind of sustain the team has been really hard fought. You had to make a lot of different kinds of arguments for why this is something that's important, what this would actually mean for the patients. And then, you know, there is always going to be that expectation to show data at the end that shows, you know, improved outcomes. Yeah, I mean, not to say that people don't care about that, but they really want to know, like, what is this money going for? How much money are we going to save later? So sometimes you have to get a little bit, I guess, creative in the way that you kind of make these arguments for how there's going to be not only a benefit to the person, you know, individually, but also a benefit financially to the system.
Thank you both, and thank you, Mark, for your question. We also had a question come into the chat. Someone asked how we can make this model that we've been discussing today more standard for healthcare. And with that, I also wanted to ask if either of you had thoughts on steps that people without disabilities or people who don't work in medicine could take to help make medicine more accessible and less ableist.
So some of the things I'm thinking about is that I'm so glad that we have all this kind of like grassroots activity at trying to really see if we can't, you know, make these big curriculum changes at individual medical schools, individual providers or physicians who are kind of coming out and saying, okay, I'm disabled, I want to do this work, like, let me show you how it is that we can do these things. But I think that to have like large system change, we're really going to have more buy-in from people that are kind of at the top of these systems, and not just buy-in saying, hey, this is great work, I love what you're doing and I encourage you to do it, but also that means funding, that means supporting disabled people who are actually trying to do this work. And then also, I think that means a kind of change in the way that we expect not just disabled, but non-disabled, you know, physicians and other providers to kind of keep learning about these things, to conduct themselves, to actually try to be champions for this disability community. Getting to what do I think that non-disabled people can do, I think one of the first things is, it sounds silly, but to do things like this, to come to these kind of lectures, to listen to these kinds of topics. There are all kinds of ways to listen to members of the disability community, and to like educate yourself on, you know, disability as identity, other kinds of disability rights topics, disability in medicine, and how all of this kind of comes together. I think that we in medicine kind of commit to being lifelong learners, but we don't always take that to mean things like, you know, the social aspects of how all this affects our patients' health. I think that another thing is that sometimes when people come in and they say, oh, hey, I'm really interested to learn about this, like I'm ready, they're not ready for the fact that sometimes disabled people are going to tell you things that you don't want to hear. They're going to tell you about how medicine has been actively harmful to the disability community, and not just in the past, but ongoing. So I think that if we can get more people that are kind of at the top who can kind of first do that kind of internal work themselves, be interested in doing that kind of engagement themselves, but also, you know, to kind of help advance these policies to come along. I think that is, I think it's would be a big change, but I think that it is a change that ultimately is probably going to be necessary.
Yeah, definitely a lot of efforts to try to take some of the products that we've been talking about and make them on a national scale. So that's been with organizations like the Alliance for Disability and Healthcare Education, medical students with disability and chronic illness, but also to bigger sort of higher profile groups like projects we've been working on with the American Academy of Pediatrics and recent changes at the American Medical Association. But for people outside of the field, building off of what Diana said, I think another place is just to keep an eye out for ableist things in your everyday life and in your interactions with, you know, the world around you, and point them out to people, both so the general population maybe starts to see them more, but also so that the people who start making these decisions, it becomes more clear that not only are these things present, but people care about this, that this is something that is everywhere, but also that is something that's, you know, causing a bit of fuss.
Thank you so much for that. Sorry, Jess. I was just thanking our presenters for that and was gonna hop into the questions. Betty, I saw that you had your hand physically raised, and you're already unmuted, so I will let you go first, and then we'll get to Ruth Ann and then Danielle.
Okay. I don't was on mute here. So what happened? I was listening to what she was saying, and she said like how she meet a lot of people and they when it comes down to disability, like an invisible disability, like I'm deaf blind, and then when I talk to people and you know where you know and their subject comes up, then you know they have questions and doesn't really understand. So I really think that was something that really needs to be talked about more. And then I also wanted to say something about I have a plan with OPWDD here, and I want people to need my I forget what you call it. Okay, I'm in need of an SSP to help me to go when I go out and I'm in the community. I need help with selecting and you know for them to like to explain my visionary what's around, because I can only like I have like a total vision, and when I tell them that they don't understand that. They want to give me like a home attendant. So yeah, right. Lots of things need to be expanded, you know, talked about, because I think there is a lot of people that's coming into the program that they have like different disabilities here. I don't know if you heard of like Usher syndrome. That's when the vision, everything is closed again. So that is it. Yes, that's one of the reasons. So and that needs to be talked about more. And thank you for everything here. Yeah, I really enjoyed what everyone touched on here.
Thank you so much. We'll go to Ruth Ann.
This is one big important thing to me, is that the mental health system needs to be improved for autistic people, and that psychiatrists need to be held accountable for the way they treat people with disabilities, and to provide informed consent and not like manipulate us, and also that the state health department needs to take it seriously when we report things and actually believe us, because when I reported some psychiatrists from a hospital in the past, and basically the state's like, oh, they did nothing wrong, but they definitely did stuff wrong. And so I think that's a bit of a big issue, and also the fact that like nobody in psychiatric hospitals, I mean even outpatient and regular therapists, have very, very little education on autism. So that's one thing I'm like, I really, really hope it's going to be changing in the medical field, that they're going to get a lot more education on autism and disabilities in general.
Thank you so much for sharing. Danielle, if you'd like to go next.
So phenomenal presentation, everyone. Like you, I am also a lineman student out of the Einstein College of Medicine up in the Bronx. One thing I'm noticing, especially as an adult, while they are having more low access tables and larger rooms, there is, if you are physically severely disabled, a lack of transfer equipment, i.e. mounted wall Hoyle lifts, even mobile units to get you up on an exam table, even if it's low. Okay, so I have the ability to stand pivot, but I am also heavier than I should be due to my sedentary lifestyle, and my parents are in their mid-70s. Right now, my father is the one who does the majority of my lifts, but if there was some grant work to be processed in that, if you are a major hospital or healthcare facility, you should have at least in every department, 1 or 2 rooms, regardless of if you are a pediatric or an adult provider, or even a pediatric provider who sees adults due to the severity of their condition, you have to have transfer equipment on site. This goes for scan rooms, this goes for transferring to a gurney, this goes for even ER access as well, because this is one of the main reasons why we don't seek treatment, because we can't access the bed even if you have them. And a second point I wanted to make is that there should be no stigma if you are an adult and you seek the services of a pediatric physician who is willing to see adults. And in fact, in this society where adult knowledge in adult medicine is scattered at best, then you should absolutely be able to, if you are willing and if the physician is willing, to have an adult area and see them on certain days, even if it's the weekend. We need this access. Yes, we are adults, but we are adults with pediatric conditions, and the majority of people who know about our conditions are in the pediatric field, and there should be no stigma.
Yeah, we didn't talk very much about my research area, but part of the population that I study has cerebral palsy. And from talking to people in that space, I hear a lot about how difficult it is transitioning to adult services, particularly for people whose cerebral palsy is more severe. You just cannot find someone who treats adults who has that sort of expertise. When I've been shadowing, there have been patients older than me there because the pediatric providers will hold on to them until they can find someone qualified and ready to take an adult. And if that takes decades, then it does.
There should be no stigma. I have cerebral palsy, spastic quad, and I am seizure prone. I haven't been followed by a neurologist in 8 years, and it's dangerous. And I shouldn't have to go to the ER shaking and convulsing just because I have no way to be managed.
Now, there's one more hand up, but we are at time, so I will leave it up to our presenters if we want to take the last question or if we want to end it here.
If there seems to be no objection, then I think we can take that last one. I really appreciate our presenters giving us a little bit extra of their time.
Awesome. B, if you'd like to unmute yourself and ask your question. And also before, just a precursor, if there's any like specific issues that you have for confidentiality purposes, just keeping the questions vague if it does involve personal matters.
Okay, first of all, what's going to happen after this meeting in terms of follow-up? That's the first question. The second question is that there's a lot of links that people posted in the chat, but I don't have the time to gather them all up and copy them. Can all those links that recommended be put in some sort of list form and emailed to us, like we got the invitation for this Zoom meeting? So all these resources could be gathered and given to us so that we don't lose it after the meeting. The other thing is, it is sort of personal, but a friend's brother was in the hospital with early signs of dementia, and they refused to give him glasses or a newspaper. And then when he became agitated, they escalated the mistreatment of him. And this is in a major hospital in New York City. How can they deprive a patient of a newspaper and glasses? And we're not even talking about a disability. We're just talking about regular reading glasses.
Thank you so much. I can say that we'd be happy to share any of the links and resources that folks have shared in the chat. I've been glancing over at it a little bit, and I definitely myself look forward to reviewing what people have shared there. It seems like we have a lot of excellent resources, so we'd be glad to email that out to everyone. And regarding, I'm not sure if this was what you meant by your question, but what will happen after this? Again, we can share any resources, and I would invite anyone to contact my office, Disability Rights New York, if you have experienced ableism or discrimination in healthcare. We are a free legal and advocacy organization, so we provide those services to people free of charge, and we are very experienced in advocating and litigating on behalf of people with disabilities in medical settings. And so we'd be glad to have you speak to our intake team and connect you with someone specialized who can assist if there is a particular issue. And I would invite our panelists if they have anything that they'd like to share as we wrap up here.
Do you have a link where I could reach out to you?
Absolutely. We can email that with the links so that everyone has our contact information as well. We accept intakes online via email and as well as by phone, and we serve people across the entire state of New York. We are mostly working from home still, though we do have physical offices in Albany, Rochester, and Brooklyn. But again, geography does not prevent us from representing someone. I just want to say thank you again to our panelists for being here today. We really appreciate your time and the few extra minutes that you've given us. We know you're exceptionally busy. I think this has been a very valuable conversation and we really appreciate it. A recording of this conversation will also be available online, and we can share that link with folks when we share the other links. And that will conclude everything for this afternoon. Thank you again, everyone, for attending.